Start.
Yes, we are live.
Okay. So, good evening, doctors and all the participants. Ishman on behalf of Shield Healthcare, welcome to you, all of you, in another very interesting session under the banner, the icons in conversation with Dr. Ritu. And the topic of the program is ovarian tumor and pregnancy. And the icon of today's program is Professor Fawzia Hossain, madam. In brief, madam leader MRCOG, NSA, MRCOG, International Affairs Secretary, OGSB. She is the Vice President of Bangladesh Society for Colposcopy and Cervical Pathology and Department of Gynecological Oncology in Bangabandhu Sheikh Mujib Medical University. And obviously, today's Dr. Ritu ma'am, all we know very well, Dr. Ritu Santwani madam. Just it's my formal responsibility to introduce ma'am once again, Madam Leader MBBS, MD, FIOG, and AMRCOG, and she is a senior obstetrician and gynecologist and infertility specialist and founder, member, and CEO of 360-degree healthcare studio in a district hospital, Pune, and she is a specialist, infertility specialist, and she is a co-founder and board member of SWWC. So, with this very short introduction of both the eminent leaders, I like to hand over the session to Dr. Ritu ma'am for further proceedings. Thank you very much.
Thank you, Dr. Suman. And first of all, warm welcome to all our dear friends who have joined all across the geography. Friends, as you always know, that this my series of the daily weekly series, in which I always invite one stalwart from the R fraternity, who can come and discuss one important topic with us. So today, none other than one stalwart from the Bangladesh, my very dear friend, Dr. Fawzia Hossain, is here with us to discuss with us the very important topic, the ovarian tumor and pregnancy. And we are very much thankful to Dr. Fawzia that in spite of having her very busy schedule, she accepted the invitation. So really, we are very much thankful to you. Dr. Fawzia, I can say two words for her. She is a beauty with brain, amazing voice and amazing academics, and amazing human being also. So friends, we all know we all are having lot of confusion to when the ovarian tumor in pregnancy, whether to operate, not to operate, what the medicines to give, and how to treat per trimester wise. So first we are going to listen from Dr. Fawzia. Later on we can ask her whatever the questions. So friends, those all of you have joined, please put your questions in the chat box. Once we finish the madam session, then we can take that question answers. Those who have joined via YouTube also, please put the comments in the chat. Chat is open, so we can take the questions from there only. So now over to you, Dr. Fawzia.
Thank you, Dr. Suman, and thank you, Dr. Ritu Santwani, for inviting me in this conversation with the icons. Though I believe I'm not an icon, I'm just a general human being, like everyone else in the world, but it is really good to be connected with you and the all the gynecologists and our postgrad students from Bangladesh and all over the world, India and all over the world. So actually, cancer cannot cripple love and the spirit. It cannot shatter our hope, and it cannot conquer the spirit. We all know that World Ovarian Cancer Day was celebrated on 8th of May, just 2 days ago. And today, my topic of discussion is on ovarian tumor in pregnancy. So we'll discuss about the benign tumors, the malignant tumors, and their management, what to do and what not to do. So, okay, should I start? Should I share my screen? If you permit?
Please. Yes, please, ma'am. That is all yours.
Is it visible?
Yeah, visible.
Okay. Okay, so as I mentioned, that ovarian tumor in pregnancy, it is actually a silent threat. And Ritu and Suman has introduced me. Well, I'm Fawzia Hossain, working as professor of Department of Gynecological Oncology, Bangabandhu Sheikh Mujib Medical University. And I'm also the International Affairs Secretary of OGSB. So I bring best wishes from my faculties of my university and all the members, President, Secretary General, everyone of the Obstetrical and Gynecological Society of Bangladesh. Now, I will divide the ovarian tumor in pregnancy according to the epidemiology the etiology, the benign ovarian tumors, how to manage them, malignant ovarian tumors, how to manage them, the diagnosis, prognosis, etc. So we all know that ovarian tumor is the 5th most common cancer in women in the world and the commonest cause of gynecological mortality because it comes and presents to us in a later stage. And majority of the signs and symptoms are similar to like having hyperacidity or putting on weight or bloatedness or something like that, which is very common. And therefore, most women actually consult the medicine specialist where they, while doing the investigations, they find an incidental ovarian tumor in their sonography, and then they are referred to us. And in the world data, 1 in 70 women will develop ovarian cancer. But in Bangladesh, the highest incidence of gynecological cancers is breast cancer, number 2 is cervical cancer, and number 3 is ovarian cancer. I think in India also the incidence would be similar. So ovarian tumor in pregnancy, the incidence is quite rare. It occurs in 1 in 190 pregnancies according to 2020 data. The previous data I had was 1 in 2000 pregnancies, but I checked while presenting this, it's 1 in 190. So it has, incidence has increased. So there is benignly, nearly all are benign and most are borderline with low malignant potential. And the management depends on the stage of pregnancy, the tumor size and type. But there is scanty evidence is available for the treatment of this condition due to lack of randomized controlled trials and other cohort studies. However, only 1 to 6% of ovarian tumors are reported to be malignant in nature during pregnancy. But you know, in last year, in 2022, I had 3 ovarian cancers in pregnancy. I will show them later on as a case report, and 2 fallopian tumors, fallopian tube tumors, mimicking ovarian cancer in pregnancy. Okay, I'll go to my next slide. So the risk factors depends on the advanced stage, history of infertility, history of endometriosis, and the genetic susceptibility of BRCA1 and BRCA2 genes. Like if the mother, sister, aunt, grandaunts, grandparent, grandmother, they have breast and ovarian cancer, then the woman is more susceptible to develop ovarian or breast cancer. That is breast ovarian cancer syndrome. Another one is BRCA1, BRCA2. Another one is Lynch type 2 syndrome, also known as HNPCC, or the inherited syndrome called hereditary non-polyposis colorectal cancer. So all these hereditary tumors constitute about 5 to 10% of ovarian cancer. And also, as I mentioned, the age, increased age, family history. White women are more susceptible to develop ovarian cancer, but however, it is not so much less common in Asia. It is the 3rd most common in our women. And also associated factors are early menstruation, late menopause, nulliparity, having a first child after the age of 30. Birth control pills decreases the risk, and in fact, it is the only chemo-preventive medication for the prevention of ovarian cancer. If it is, it can decrease it by 40 to 50%. And multiple pregnancy also decreases the incidence. Fertility drugs like clomiphene, citrate, menotropes, these are associated with ovarian cancer, but they do not cause cancer actually. And danazole increases the androgen levels. Estrogen and HRT can increase the incidence. Talcum powder was considered carcinogenic, but I couldn't find any reference regarding this or any research paper. Smoking and alcohol is also associated with the incidence of ovarian cancer. As I mentioned, then what are the signs and symptoms? Like, for example, in the early stage of disease, the woman may present with fatigue, bloating, constipation, difficulty eating or feeling full quickly, backache, chronic cough, indigestion. Like, these are the common symptoms of pregnancy. That is why in pregnancy, we often do not find or diagnose an ovarian cancer, ovarian tumor. Well, in the urban areas, we do routine ultrasound scan first in the first trimester, then the anomaly scan at 22 to 24 weeks, another growth scan at 28 weeks, or a fetal biophysical profile. There we can find an incidental finding of the existence of a brain tumor. But in the rural areas, they hardly have any ultrasound scan done. They come with labor pain and they deliver. And even despite the higher incidence of C-sections in our country, in Bangladesh, still there is home delivery and vaginal delivery of about 70%. So again, in the late stages of the disease, there is abdominal mass and ascites, abdominal pain, unexplained weight loss, cachexia, and pleural effusion. And again, the abdominal mass, ascites, I mean, this may, be, people might think, a woman might think that it is the pregnancy that is growing. Abdominal pain is also quite common during pregnancy. So these actually mimic other diseases, and often they are not diagnosed in the proper time at the early stage. As I mentioned, these are the benign tumors. This is dysgerminoma, the commonest germ cell tumor which occurs during pregnancy. This is a hemorrhagic cyst with intracystic hemorrhage. This is luteum of pregnancy, which is completely benign. Before taking out the ovarian tumor found during C-section or an emergency laparotomy for acute abdominal pain during pregnancy, we must be sure that this is not luteum of pregnancy, because this is totally a normal physiological condition. Another condition is ovarian hyperstimulation syndrome. Nowadays, in Bangladesh, I think that their subfertility, incidence of infertility is growing. In Bangladesh, the majority of the cause is tubal blockage due to increased pelvic inflammatory disease. So women are getting treatment for secondary subfertility, primary subfertility, and a large portion of our men are working abroad. And so women with no logical cause of infertility, they want ovulation induction because the husband is going to come visit her for only 2 months or 3 months, and the gynecologist, they prescribe ovulation induction agents so that she can get pregnant while her husband is visiting her home. So we often get this ovarian hyperstimulation syndrome, and this may present with acute abdomen and like ovarian cysts like this. So as I mentioned, the simple cyst may be hemorrhagic cyst, ovarian hyperstimulation syndrome, as I already mentioned, endometrioma, luteuma, Brenner's tumor, and epithelial tumors like serous, mucinous, endometrioid clear cell carcinomas, dysgerminomas, embryonal carcinomas are the various components of germ cell tumors. And how might other pelvic mass in pregnancy present to us? Like, apart from the varieties of ovarian tumor like sex-coat stromal tumors like granulosa cell, sclerosing Sertoli Leydig cell tumors, Kuchenberg tumors, these are ovarian tumors, but sometimes hydrosalpinx or heterotrophic pregnancy can cause an acute abdominal state during pregnancy. And sometimes it may be a paratubal cyst. Sometimes pedunculated subserous fibroid or broad ligament fibroid may present as ovarian tumor. The other non-gynecological conditions may be appendicular mass, mesenteric cyst, diverticular disease, pelvic kidney, urachal cyst. These are very uncommon, but still we have them. Now, this is what a paratubal cyst looks like. This is totally benign. And this is the mesenteric cyst, sometimes may be similar with the sign symptoms, and even in ultrasound scan, it may present as an ovarian mass. Here is an incidental finding of appendiceal mucinous neoplasm. This was cancer during an acute abdomen in a woman in the first trimester of pregnancy, and it was found to be an appendiceal mucinous neoplasm. And this is what a pelvic kidney looks like. So these may be undiagnosed conditions, benign conditions, I would say, which are may be found during pregnancy. And again, benign tumor is more common, as we have mentioned earlier, and malignant is rare, 1 to 6%. and benign tumors 1 in 90. So again, the management or the prognosis depends on the size, the gestational age of the woman. So what might happen? The ovarian tumor might rupture, or there may be hemorrhage, and there may be torsion in up to 5% of cases. Here you see the torsion here, subacute, and this one is acute because there has been intracystic hemorrhage as well. So this will present as an acute abdomen with pregnancy. And this is not going to pain, but intermittent pain in pregnancy, okay? So, and what happens during labor? She might have an obstructed labor, or she might present with fetal malpresentation. Malignant ovarian tumor may be rare, but it may be fast growing and it may be aggressive. This is one mucinous epithelial cancer. This one is my patient in Bangabandhu Sheikh Mutty Medical University last year. One of the patients I mentioned, it was a first trimester pregnancy with bilateral ovarian tumor. We counseled her and we did a frozen section, and it came out to be malignant. So we did the complete cytoreductive surgery. It was good that she had 2 other children beforehand. So the treatment depends upon the stage and extent of tumor. And usually the treatment of malignant ovarian tumor is surgery, maybe chemotherapy or combination of surgery and chemotherapy. Now, how do we diagnose? So if we suspect ovarian tumor, we have to take the medical history, physical examination, and all the other investigations should be performed to properly diagnose and manage it. So from history, in case of pregnancy, we also take history like regularity of menstrual period, previous pregnancies, contraception, breastfeeding history, previous cancer history, or whether she had her personal history of any breast or ovarian tumor, something like that, and family history, of course. Then we examine the woman, and abdominal examination, apart from the pregnancy, there might be signs of distension, dilated veins, tenderness, and shifting dullness, or presence of ascites. Bimanual examination could be done, and the other diagnoses are ultrasound scan, MRI, color Doppler, or CT scan. We also perform some blood tests known as tumor markers, by which we can determine that the tumor may be benign or tumor may be malignant. And in case of bimanual examination, it is detected if it is at least 5 centimeters in diameter. But with pregnancy, it is very difficult to do this sort of bimanual examination. I think we mostly, if it is first trimester, we won't be able to palpate the uterus, of course, beyond 12 weeks. And in ultrasound scan is the best determining factor for the diagnosis of ovarian tumor. And apart from the imaging tests, we do some routine examinations like complete hemogram, the renal function test, the liver function test. We do fasting blood. Here it is written random blood sugar. We don't do that. We do fasting blood sugar 2 hours after, 75 gram glucose, and HbA1c if a woman is not diagnosed with diabetes. And if she is diabetic, we do a random blood sugar and HbA1c. Extra chest, sometimes with shielding the pregnancy, and may be required if we are planning for surgery. Echo may be needed, and imaging is ultrasound scan, CT scan, or MRI. So I'll go through the findings of benign and ovarian malignant tumor in pregnancy with ultrasound, CT scan, and MRI. Now, benign, I'm not going to say it is unilocular, non-septated, cystic inconsistency, but and no ascites, except for solid ovarian tumor, which might be associated with ascites, but that is not malignant. The malignant cyst here in ultrasonic scan, there will be increased of the thickening of the wall and presence of nodularity in the wall. The septations will be greater than 3 millimeters in diameter. There are papillary projections, solid component, the most significant predictor of malignancy. The ascites, positive predictive value of 95% for malignancy, if it is present. Now, when do we perform an MRI? If the ultrasonographic findings are suspicious and the clinical findings are like it's partly cystic, partly solid and rapidly growing, acute pain, she's losing weight, or it is not properly visualized in ultrasound scan, inadequately localized. Disadvantages are that MRI is more expensive, we all know, and more time consuming than ultrasound scan. But advantages are greater than ultrasound scan because it is very safe in pregnancy because of the lack of ionizing radiation compared with CT scan. And it is very good at defining endometriotic and dermoid cyst. And there is superior resolution when compared with CT scan and creates images in several planes. And CT scan has little place in pregnancy in modern obstetrics. We all know that. Next, coming to color flow Doppler, which we always do, like transvaginal sonography or ultrasound sonography with color Doppler flow. Here, what do we see in color Doppler flow? In malignant lesions, it is very highly vascular, and their resistance and pulsatility indices are less than 1. Benign lesions demonstrate little or no blood flow. Now, benign conditions like endometriosis, corpus luteal cyst, and other complex masses have the same picture as the above. Okay, why? Because there is increased pelvic vascularity in pregnancy, and this overlapping of the indices in both benign and malignant lesions, Doppler imaging is unreliable. Whilst Doppler imaging is very reliable in a non-pregnant woman with ovarian tumor, it is the most unreliable in a woman with pregnancy. Because of the increased pelvic vascularity, the RI-PI indices are all messed up. Now, what about the tumor markers? Usually, the tumor markers we do are CA125, CA99, carcinoembryonic antigen, inhibin, lactate dehydrogenase, alpha-fetoprotein, and beta-HCG. So in the non-pregnant state, CA125 is this increases in 75% case, increases over 75% in epithelial ovarian cancers. Serum inhibin is detected in women with granulosa cell tumors and mucinous carcinomas. Serum alpha-fetoprotein beta-HCG is useful for the diagnosis and management of germ cell tumors, because in germ cell tumors, these will be highly raised. Serum lactate dehydrogenase raised in ovarian dysgerminomas. Now, what happens during pregnancy? Again, the serum alpha-fetoprotein, beta-HCG, and inhibin levels all are raised because these are synthesized in the placenta, and its use is limited. The serum CA125 levels elevated during pregnancy is due to the decidual cell production, with levels rising as the pregnancy progresses. And in some research papers, they have suggested using a cutoff level of 112 units per ml as the upper limit of normal during pregnancy, compared with 35 units per ml in the non-pregnant state. And the usefulness of this marker is still restricted. Even with a raised CA125, we have to do further evaluation with MRI. Now, again, a very simple question: what are the causes of elevated CA125? Yes, it is elevated in both malignant and benign conditions, in gynecological cases, and in non-gynecological conditions. Now, what are the malignant conditions where the cancers are the serum CA125 is elevated? One is epithelial ovarian cancer, some germ cell tumor or stromal tumors, fallopian tube cancers, endometrial and endocervical cancer, CA125 is raised. In non-gynecological cancers like pancreatic, lung, breast, and colon cancer, CA125 is also raised. Now, what about the benign conditions where CA125 is raised? Just being pregnant, the state of pregnancy itself can cause raised CA125. Like you see here, it's normal pregnancy. And if anyone is menstruating here, if you do a CA125, your level will be raised. In case of pelvic inflammatory disease, ectopic pregnancy, fibroid uterus, adenomyosis, endometriosis, it is raised. These are the benign gynecological conditions. And what are the non-gynecological conditions? All inflammatory states like pancreatitis, cirrhosis of liver, cholecystitis, passive liver congestion, peritonitis, peritoneal TB, sarcoidosis, even recent laparotomy can cause elevated CA125. So it is actually used for the prognosis of the disease. Like before surgery, what was the level of CA125? After surgery or after chemotherapy, has it decreased? That is how we see the prognosis of disease. So the definitive diagnosis is surgery or biopsy, we all know. Laparoscopy can be used during pregnancy with caution, and the person doing it should be highly skilled because we have to avoid the rupture or the spillage of cancer cells or the tumor itself. Frozen section diagnosis of ovarian cancer and staging is mandatory. So the management depends on the size, sonographic appearance, and the symptoms. So what can we do? We can observe, or if she is having pressure effects or acute pain, then we can do an aspiration, or the final treatment is surgery. So in which cases shall we just observe the woman? If there are simple cysts and less than 5 centimeters, no further evaluation. We can do a rescan if there is pelvic pain, and majority of them resolve spontaneously. And if there is a complex cyst, or we can actually follow up with ultrasound scan whether it is increasing or not. In the majority of cases, resolve during the course of pregnancy. Now, while we are observing, the adnexal muscles can undergo torsion. Dermoids and cyst adenomas during the first trimester or immediate puerperium, which is up in the first 14 days, they have been shown that they cause torsion. Dermoids less than 6 centimeters can be managed conservatively, and risk of complication torsion is low, and rescan in the postnatal period to determine further management. Now, why the new conservative concept? Torsion is rare till postnatal, and most malignancy are borderline or of low malignant potential. We all know that MRI can differentiate most malignancy, and surgery can be postponed till at the second trimester in 10% of cases. And this is how the conservative concept has risen. Secondly, we can do aspiration. The indications are persistent, simple unilocular cyst, more than 10 centimeters, causing pain, or which is increasing with the risks of causing fetal malpresentation or obstructed labor. In those cases, we can do some aspiration. Now, timing should be after 14 weeks so that it minimizes the disturbance to the corpus luteum. And how do we do it? It may be done transvaginally or abdominally, again with a very skilled person under the guidance of ultrasound scan, and the needle should be greater than 20 gauge. Local anesthesia for the skin should be given. We should be given her prophylactic antibiotic. The fluid which we have aspirated should be sent for cytology and rescan to see if there is recurrence. Now, what may be the complications? These are well tolerated without short or long-term complication. Recurrence is 33 to 50%. Further aspirations can be required during the rest of the pregnancy. And the third, or the most common management, is surgery, and the indication depends on the degree of suspicion of malignancy, development of complications, timing after 14 weeks gestation. And we have to minimize the risk of fetal loss due to the miscarriage, because miscarriage can occur, although this risk is very small. Now, the pregnancy is dependent on the corpus luteum, we all know, during the first trimester, and much less so after 12 weeks. So therefore, timing is usually in the mid-trimester at 14 weeks gestation. Again, what may be the approach? We can either do a laparotomy or laparoscopy. So for laparoscopies, I have mentioned it is skill dependent. It's more time consuming than open surgery, but the endoscopic surgeons will not agree with me. They will say that laparoscopy is quicker for them because they are very, confident and very much into it. So that also, if we are doing laparoscopy, it should be again done during the second trimester, And usually we don't do it infraumbilically, or we do the open method or Hassan's technique to avoid uterine injury from the primary trocar introduction. Now, tocolytics is not routinely necessary, but if there is uterine irritability, tocolytic regimens can be employed. This was one case in Bangabandhu Sheikh Mujib Medical University in my unit, 12 weeks, 10 weeks pregnancy perhaps, and this was a borderline ovarian tumor. The tumor markers were raised. You see the huge mass. So we operated, even though she was 10 to 12 weeks, we had to, because the tumor markers were raised, and we sent for frozen section. It came out to be borderline. So we did the unilateral starting operectomy. Okay. Okay. Now, what happens now if she didn't have any prior ultrasonography scan, or it's not available? You are someone who is attending the woman during her labor. So adnexal mass discovered at C-section. Normally, after we perform a C-section, after closing the uterine wall, we check the fallopian tube and the ovaries. If there is anything, we take out the entire uterus and see. We visualize it. Routine practice. Sometimes at cesarean section, the most common lesions found are dermoid cysts, Paratubal cysts, cystadenomas, endometriotic cyst, corpus luteal cysts. These are the most common ones. Now, if we find one ovarian tumor, small tumor, or whatever, during C-section, what should we do? If it is a simple cyst, less than 5 centimeters, should be left alone. Simple cyst greater than 5 centimeters or complex cyst, we should perform a cystectomy after a C-section. Now, after cyst removal, the content should be inspected, and any signs of malignancy. Is there any solid excrescences or papillary projections? In that case, we don't do cystectomy, we do an oophorectomy, or if available, rapid frozen section should be done. And the precaution should be, we have to avoid the intra-abdominal contamination, because we do not know whether it is benign or malignant. And sometimes if it is a mucinous cystadenocarcinoma or mucinous cystadenoma, if the mucin spillage is there, she might develop pseudomyxoma peritoneal, which is so horrible, you all know how it is. So no intra-abdominal contamination. The contralateral ovary should be examined, and if indicated, biopsied accordingly. Now, when do we do a surgery or resection during C-section and incidental finding of ovarian tumor? If it is ruptured, or there is torsion, or it might be capable of obstructing labor, I'm talking about, not during C-section, but surgical management. If it is more than 10 centimeters, there is increased risk of cancer in large cysts. And again, as I mentioned, that they contain septa, nodules, papillary excrescences, or solid components, then it is most likely that it is a malignant tumor. So in case, if the cyst is 10 centimeters or less, it is observed, and sometimes it requires emergency exploration for rupture, torsion, or infarction in some studies. Like the previous case I showed, probably there was intracystic hemorrhage due to torsion because the pedicle was too long. Now, again, the management is laparoscopy to evaluate and resect intermediate size cyst, and the major concern is for the unrecognized malignant tumor rupturing with the intraperitoneal spillage. And in fact, I'm just repeating the same thing, no intraperitoneal spillage while we are operating with laparoscopy or by laparotomy. Now, there are 3 questions which we have to ask ourselves. When a pelvic mass is discovered during pregnancy, we have to ask or give the answer, what is the mass and what is the likelihood that it is malignant? MRI can correctly identify the origin of unknown pelvic masses. Now, number 2 question we have to ask ourselves is that, is there a good possibility that the mass will regress? And if observed, we are observing, we are not doing aspiration, we are not doing surgery. Will the mass undergo torsion or rupture, or will it be an obstruction to vaginal delivery? So the time, the serial ultrasound scan, and the labor will provide answers to the last 2 questions, whether it will regress or it's going to rupture or undergo torsion. Now, there are some recommendations. I've got it from 2010. I don't see any recent, I didn't find any recent recommendations. So we have to resect it if it is greater than 10 centimeter and risk of malignancy and torsion is more. If it is 6 to 10 centimeter, we can do ultrasound with colored Doppler or MRI, whether it suggests a neoplasm or a benign tumor. If it is less than 6 centimeter, and if she becomes symptomatic, if the corpus luteum is removed before 10 weeks, and we have to do laparotomy or laparoscopy to remove that tumor, then we have to give 17-hydroxyprogesterone or 250 milligram IM per week till 10 weeks of gestation. Sometimes some people say 14 weeks of gestation, where the corpus luteum actually gives us support, and the placenta is formed usually by 14 weeks of gestation. And how can we observe? By clinical examination. Definitely we are examining her and writing down in our prescriptions and in her notes by diagrams, and also with serial ultrasound scans. So cystic masses that are thought to be benign less than 6 centimeter, we can do an elective surgery at 14 to 20 weeks. Most masses that will regress will be done so by this time. And the mode of delivery will depend upon the condition. Like patients in whom the asymptomatic mass is noted at or near term may be considered for delivery by C-section with careful intraoperative evaluation of the adnexa, that is by keeping frozen section facilities. Vaginal delivery in this situation has been associated with torsion. Like if we allow the woman to have a normal vaginal delivery and keeping the ovarian tumor not just observing. So vaginal delivery is usually associated with torsion, rupture, and hemorrhage that can occur during labor or immediately postpartum. The size and ultrasound characteristics of the mass will help to guide the clinician's decision concerning the best route of delivery, whether we are going to allow her for a normal vaginal delivery or we are doing C-section, and at the same time we are doing the definitive surgery. We have to individualize each woman. Now, what are the surgical tips? The best time for dual laparotomy is 16 to 8 weeks, as we have previously mentioned. And a vertical midline incision is preferred, or sometimes we can give we have to give the incision in a higher level so that the uterus is not injured. The uterus should be, we can give a paramedian, I meant, the lower midline longitudinal or paramedian incision can be given, and the uterus should be handled gently. And while we are exploring or taking out the tumor, the uterus should be, there should be given frequent irrigation so that we prevent the uterus and other tissues from drying. So when ovarian cystectomy is required, an internal closure with use of 5-0 suture Vicryl is recommended. And sometimes we can decide not to do any closure, depends upon the tumor. And the traditional Buxton type closure should be avoided. Now the surgical tips: before the decision is made to perform oophorectomy, we have to exclude the tumor of pregnancy, which is a benign and physiological condition. And in case of malignancy, total abdominal hysterectomy and bilateral salpingectomy are done, but it is rarely indicated unless it is a malignant ovarian tumor. Now, what may be the postoperative care? After doing the surgery in mid-trimester or after delivery, the role of, before delivery, role of progesterone to prevent labor in the postoperative period is not very clear, but we often give it empirically. And progesterone should be considered if the surgery occurs in the first trimester, definitely. The patient should be monitored for contractions and fetal hearts checked. If contractions occur, it can be treated by hydration, sedation, or standard tocolytic therapy. We can also give indomethacin if it is before 32 weeks, because beyond 32 weeks, we don't use indomethacin or NSAIDs because it causes premature closure of fetal ductus arteriosus. Now, this is a case report of a woman I operated last year. Very sad. She was referred to me from a remote area of Bangladesh. She was 27 weeks pregnancy, and she had huge abdomen, and she was so unwell. They thought it is the pregnancy, maybe a multiple pregnancy, whatever. The woman was only 25 or 26 years old. So they referred the woman to me, and because of the pain and the huge distension of the abdomen, they did an ultrasound scan, and it said that there is pelvic mass. So before she was, transferred to our capital here, she actually had a premature delivery, and she delivered a preterm baby girl at 27 weeks. So she was, admitted in the NICU in my clinic. And this is what you see. Just maybe the day before she had a vaginal delivery. Look at the bilateral huge ovarian tumors. I don't know whether you can ascertain how big it was. And I was so shocked, Look at this. These are not small gallipers. These are huge bowls. The largest size. Do you have bowls in Indian theaters?
Yes.
This is the biggest one, and each weighed around 21 kilos. Can you imagine? This very less than 5 feet height young girl, she was carrying her baby who was 1 kg or 1.1 kg, I think. And these 42 kilos tumor. So I removed, and this was, and her tumor markers were raised. I actually did total abdominal hysterectomy and the complete surgery, complete cytoreductive surgery. And it was so huge, and did the pelvic lymphadenectomy as well, and infracolic omentectomy. And I was doing the surgical exploration. Then I found there was a nodular structure in the stomach.
Oh.
So we do routine surgical exploration, like if there are any deposits in the paracolic gutter or in other organs. So there was one growth in the near the duodenum, like what is called in the lower part of stomach. So later it came out to be secondary adenocarcinoma of ovary. So the origin was from stomach, probably. But I told them that you need to have an endoscopic biopsy to confirm the diagnosis. However, she was in chemotherapy. Baby did not survive, but the woman is still alive after chemotherapy. But you see, you might say that, why did you take out the uterus? Look at the huge ovarian tumors. No use in keeping her uterus, right? We have to save the life of the woman. The baby did not survive. That was bad luck. And we don't have so much in ICU support that a 27-weeker who was born at home in vaginal delivery, she could survive. Anyways, the woman is still alive. That is what it matters. This is another case which I showed earlier. First trimester pregnancy with bilateral ovarian tumor. So actually what she did, she was pregnant and she was feeling very heavy and all that, and she didn't want this pregnancy. She had a medical termination of pregnancy by herself. Sometimes in Bangladesh, we do have MM kits, the medical abortion drugs, in the pharmacies, and they buy and they do self-injection. So this is what happened to her, and she was having abdominal pain and all that, and she thought she was putting on weight. She didn't realize she had bilateral ovarian tumor. So after the miscarriage or partial miscarriage, I don't know. She was referred to us, and all the tumor markers were raised. And so we did a total abdominal hysterectomy with bilateral salpingo-oophorectomy. These are the pelvic lymph nodes. These are the common the common iliac lymph nodes, and these are the pelvic lymph nodes. These are the pre-aortic and para-aortic lymph nodes. And I had to call the vascular surgeon because they were so large, just to keep them if I do an injury incident accidentally, so that we called the vascular surgeon as well. So they didn't have to do anything. We could manage removing all the lymph nodes. Look how enlarged it is. More than 6 centimeter and 4 centimeter in diameter. So this is we did the total omentectomy as well. So these are the two interesting cases I've mentioned. And histology, I don't want to say, you all know this, that 85% of ovarian cancers are epithelial in origin. and majority of them are serous, 40 to 50%. Endomucinous is 6 to 16%, endometrioid 5 to 25%, and clear cell carcinoma. And then another variety is germ cell, which constitutes about 10% of all ovarian cancers, and sex-caused stromal tumors constitutes about 5% of all ovarian cancers. Now, women who have a pelvic mass that raises suspicion that it might be a malignant ovarian tumor, they said that these women should be sent to a gynecological oncologist or to a center that specializes in gynecological oncology. So if there is elevated CA125, ascites, nodular, or fixed pelvic mass, there is evidence of abdominal or distant metastasis or family history of one or more first-degree relatives, whether ovarian or breast cancer, these women should be referred to the tertiary referral centers. And of course, we have to do the staging, and sometimes 1/3 of the stage 1 or 2 can be, upstage while we are doing the surgical exploration. So Vigo staging, I'm not going to do, it's all in the textbook. And we all know that surgical, complete cytoreductive surgery or debulking surgery is the main treatment of ovarian cancer. And the recommended staging, you all know, but just for a brush up for the postgrad student, I'm just saying that usually with ovarian tumor, we do a vertical incision and we take multiple peritoneal washings if there is no ascites. About 100 to 150 ml of normal saline or distilled water is given in the right left paracolic gutter on the surface of diaphragm and in the pouch of Douglas, and we take the peritoneal washings. And then we perform total abdominal, we remove the tumor and send it for frozen section biopsy. So what if it comes to be malignant, then total abdominal hysterectomy, bilateral salpingo-oophorectomy is done. And if it is germ cell tumor or very early stage epithelial cancer, then we can actually just do a unilateral salpingo-oophorectomy. Infracolic omentectomy, pelvic para-aortic lymph node sampling or dissection, we do the complete dissection. Peritoneal biopsies, if there is no evident deposit, we take biopsies from the pouch of Douglas, rectal and bladder serosa, on the right and left paracolic gutters, pelvic side walls, right and left undersurface of diaphragm, or if there are any adhesions. This is how to do the surgical staging if no deposits or involvement of any viscera is there. Therapy, we all know that complete cytoreductive surgery, and sometimes in higher stage advanced cancer, they require adjuvant therapy with combination carboplatin, paclitaxel chemotherapy. Ovarian tumor, what it looks like. So I will not go through the chemotherapy, just 3 more slides I'm going to just discuss. What is primary cytoreductive surgery, what is secondary cytoreductive surgery, and what is interval cytoreductive surgery. So patients who undergo optimal cytoreduction, cytoreduction means in the previous slide I showed all the steps. So they have improved response rates to chemotherapy and the prolonged disease-free survival and improved overall survival. So primary cytoreductive surgery, if we can perform it. And the optimal cytoreduction is defined as a tumor measuring 0.5 centimeter or less residual tumor that we can keep. But best survival rates when no gross visible tumor is remaining. So this is what we did, a primary cytoreductive surgery in a woman with pregnancy in first trimester. This is sometimes splenectomy is also required. So we take help of the hepatobiliary surgeon. This is the inferior vena cava and the aorta. This is the enlarged lymph nodes that are similar to the one I removed here. Again, the great arteries and veins, the great vessels. Now, what is the interval cytoreductive surgery? Like, it is chemotherapy followed by surgery. If we think that it is very high in stage, I'm not able to do a complete surgery, if it is matted, if the huge ascites, if she has a bilateral pleural effusion or the lungs are involved, she cannot go anesthesia, prolonged anesthesia. So we can give chemotherapy, like neoadjuvant chemotherapy, 3 cycles, and then it helps shrink the tumor, then we can do the surgery. This is known as interval cytoreductive surgery, that is chemotherapy followed by surgery. And secondary cytoreductive surgery is done in the setting of recurrent disease. And the selection should be based on disease-free interval from completion of primary therapy and number of sites of recurrence and others. Chemotherapy, 75 to 80% of patients will respond to chemotherapy, but standard treatment is surgery followed by chemotherapy. I'm not going through the chemotherapy, just few things. The primary peritoneal carcinoma, there is no ovarian mass. There is only ascites. So this is the serous carcinoma arising from the peritoneal lining that is histologically indistinguishable from serous epithelial ovarian cancer. So there is widespread abdominal disease with only surface ovarian involvement. We can see only the ascites. So this responds to therapy similar to epithelial ovarian cancer and managed in the same way. So primary peritoneal carcinoma, we had one in 2021, and previously we had, I'm just talking about last 2 years, and fallopian tube cancer. In last 6 months, I had 2. So this resembles, there is no ovarian mass or whatever. Just incidentally, I palpated like what could be the origin, like from liver, undersurface of diaphragm, from pelvic cavity, palpating the intestines, this large intestine, small intestine, nothing was found. Then just the fallopian tube was a bit tubular structures. Sent it for frozen section, and it came out to be malignant. So performed the complete cytoreductive surgery. So it resembles papillary serous carcinoma of the ovary, and the surgical therapy is the same, symptoms similar to ovarian cancer. And the most common symptom is hydroria, like watery fluid coming from the vagina and vaginal bleeding. Germ cell tumor is similar, but HCG, as I've already mentioned, different tumor markers like beta HCG alpha fetoprotein, but in pregnancy, we don't rely on these tumor markers. Again, complete cytoreduction and same surgical staging as epithelial ovarian cancer, but only if the woman is planning to have more children, then we can do unilateral salpingo-oophorectomy, that is fertility preservation surgery. But after delivery of her child, we have to do the complete cytoreductive surgery. That's the management. So how do we follow up the woman? In first year, we have to do every 3 months. In year 2, every 4 months. Year 3 to 5, every 6 months. And in each setting, each visit, we do a pelvic examination and CA-125 in each visit. That is how to do the follow-up care. But in case of pregnancy, actually, we do 7 days after the delivery and at 6 weeks after, at the puerperium, and then 3 months in first year. So these are my references, and that was all. And thank you, Dr. Ritu Santwani, once again. You're our good friend of Bangladesh, and you're our pride in this region. Thank you so much. And thank you for hearing.
Thank you so much, Dr. Fawzia. Such a well-presented lecture. You have covered each and everything. Slides are so informative. All the things from the beginners to the expert, you have explained each and everything. Lot of doubts which the beginners have, that which incision to take, how to do the lymph node dissection. You have covered each and everything. So friends, if there are any questions, you can write in the chat box so we can take that questions. But that's amazing that you have taken, you have seen 2 fallopian tube carcinoma in the
last year. Very uncommon.
Yeah.
I think it is very common nowadays because in 1 year I found last 6 months.
Yeah. Thank you, Renu madam. Dr. Fawzia, Dr. Renu madam is joined from Kanpur, a very busy practitioner from the Kanpur.
Thank you, ma'am. Thank you so much.
And Dr. Ritu Dua is from Mirzapur. She is also writing a very good
presentation. I'm so
presentation.
honored. I'll just take away my screen so that I can see everyone. Thank you, ma'am. Thank you for joining. I'm so much honored. Thank you so much.
Yeah, so many doctors are writing. Dr. Niharika is also writing.
Yes.
Very nice presentation. Yes, Dr. Khalida has joined from KSA. She usually joins for all my webinars. Yeah. See,
Thank you.
So many doctors are writing. Yeah, for the very nice
I'm
presentation.
really honored, extremely honored.
Very nice. Yeah. Thank you, Dr. Shabina, for joining also. So usually my program timing is up to half an hour. Now, how this 1 hour is passed, we all are mesmerized by seeing your slides. Huh? So thank you. I think there are no questions, only all the appreciations we are getting. So thank you so much, dear Dr. Fawzia, for taking out your time and sharing your immense knowledge with us. Hopefully, I will able to invite you sometime in person, especially in Pune, to have your wonderful lecture. Yeah.
Thank you so much. Lastly, I would like to say that cancer is a marathon. You cannot look at the finish line. You take it moment by moment, sometimes breath by breath, other times step by step. So that is how we look at cancer. So thank you very much for patience hearing. I think I overtook your time. Sorry.
No problem. But your slides are mesmerizing. We all are means so much. Your slides are saying each and everything you have covered. So that's really wonderful. Thank you once again, Dr. Fawzia. So friends, with this we are winding off for today's session. Thank you to all the delegates, also all the friends who have joined all across the geography. So friends, and thank you to Dr. Suman and Shield Pharma for providing me the platform for this weekly series. With this, we will wind up for today. I will be back soon again on the another week with some interesting session. Before we wind up, friends, please block your 18th June for the academic marathon. All the details I have already posted on the social media. So that will be a one academic feast with lot of stalwarts I have gathered from all across the geography. So till then, bye-bye.
Okay.
Thank you,
Good
madam.
night. Have a great weekend. Allah Hafiz. Namaste. Thank you.
Namaste. Thank you.
You can stop.